Welcome everyone to today's webinar on how states can leverage hospital community benefit policy to advance community health and equity. We're very excited to host today's webinar supported by the Robert Wood Johnson Foundation. Since 2017, the National Academy for State Health Policy has convened state officials to address transparency, reporting, and impact of hospital community benefits spending. We've convened this group to support states in using the various legislative and regulatory levers at their disposal to ensure hospitals invest in their communities to improve population and community health. Next slide, please. I'm Jill Rosenthal. I'm a Senior Program Director at the National Academy for State Health Policy. For those who may not be familiar with NASHP, we're an organization of, by, and for state health officials dedicated to helping states work across branches and agencies of state government to find solutions to states' most pressing challenges. We focus on researching, identifying, and supporting states to advance innovations in state health policy. And this work on state community benefit policy fits squarely within that mission. The COVID-19 pandemic has impacted state budgets and illuminated racial and ethnic health disparities that existing health improvement efforts have not adequately addressed. As a result, it's more important than ever that nonprofit hospitals provide meaningful community benefit investments in exchange for the large tax exemptions that they receive. State leaders are using policy levers that go beyond the federal community benefit requirements to hold hospitals accountable for their commitment to improved community health. And we'll hear about efforts in 2 states to do that today. We have a fantastic panel of speakers, and in a moment I will turn to our panelists and we'll save some time at the end to answer questions that you can submit in the Q&A Zoom feature. At the end of the webinar, we'll ask you to please fill out a survey to help us best meet your state health policy needs. Webinar panelists today include Ali Atkinson, who's a policy associate at NASHP, and she'll provide an overview and some context about hospital community benefit investments, how these investments address or could address community needs, social determinants of health and equity, and state opportunities to ensure meaningful spending. She'll be followed by 2 panelists from the Massachusetts Office of Attorney General Maura Healey. Sandra Walitsky is Assistant Attorney General, and Noam Yosefi is a healthcare analyst in that office. They'll discuss the evolution of community benefit reporting in Massachusetts and their updated guidelines. Next, we'll hear from 2 panelists from the Oregon Health Authority. Amy Clary is Research and Data Manager, and Stephen Ranzoni is a Hospital Policy Advisor, both in the Office of Health Analytics. They will discuss Oregon's Hospital Community Benefit Program and recent efforts to address health equity. Next slide, please. Before we get started, I want to remind you that participants are currently in listen-only mode, and you can share your questions by typing them at any point in the Q&A box. And now I will turn it over to Ali for an overview.
Good afternoon, and thank you for joining us today. To begin, we want to center our discussion on community benefit policy with our current health equity landscape. COVID-19 has highlighted longstanding health inequities across the US and disproportionately impacted communities of color. At the same time, state budgets are facing revenue shortfalls and budget cuts, limiting their ability to meet community health needs. Hospitals are a critical resource in our COVID-19 response, and recently they have received significant federal relief funding for their role. In exchange for the tax exemptions they receive, nonprofit hospitals can play an important part in COVID-19 recovery by making meaningful investments in their community to address critical health needs. Meaningful investments in social determinants of health can reduce health disparities and advance equity. Research shows that investments in housing, income, and nutrition support have positive impacts on health outcomes and reduce healthcare spending. Care coordination and community clinical linkages help address patients' social needs and reduce racial disparities. As anchor institutions embedded in communities, hospitals play an important role and have an obligation to address community health needs through investments in upstream drivers of health. In order to advance community health, hospitals must learn what communities need in partnership with community members. The Affordable Care Act requires nonprofit hospitals to conduct community health needs assessments every 3 years in order to maintain their nonprofit status. Hospitals must consider input from at least one state, local, or tribal public health department, as well as from medically underserved, low-income, and minority populations in their communities. A 2016 analysis of community health needs assessments found that the top challenges for communities included access to care, the food environment, and education. Top health conditions cited included mental health conditions, diabetes, and substance use disorder. Hospitals must also develop an implementation strategy to address identified community needs. The implementation strategy must describe how the hospital intends to address significant health needs and/or explain why the facility is unable to address the identified health needs. Importantly, under current rules, hospitals must make their community health needs assessments widely available. An analysis of community health needs assessments and implementation strategies show that hospital community benefit dollars do not always meet identified community needs. The 2017 study found that a majority of community health needs assessments reference health disparities and health equity explicitly, and 75% of stakeholders identified a need for health equity. However, only 9% of hospitals included an explicit strategy to address health disparities in their implementation strategies. Furthermore, since there is no required connection between the implementation plan and community benefit expenditures, it is impossible to tell if hospitals are addressing these disparities. Since 2009, hospitals have reported their community benefit expenditures using the IRS Form 990, Schedule H. This form includes categories shown here, including charity care, unreimbursed Medicaid expenditures, research, donations to community groups, subsidized health services, health professions education, and community health improvement services. In 2011, nonprofit hospitals received over $24 billion in tax exemptions. And from 2008 to 2012, about 8% of hospital spending went towards community benefit services. Recently, the 2020 IRS report to Congress included community benefit data for tax year 2016, shown here. The data shows that over half of community benefit spending went towards direct patient services, including charity care and unreimbursed Medicaid, while community health improvement made up only 3% of spending. Therefore, under current federal rules, community benefit oversight and spending are inefficient for improving community health and advancing equity. First, there is no federal minimum spending level for community benefits required for nonprofit hospitals, despite the large tax exemptions they receive. Additionally, when examining the current community benefit spending, the amount towards addressing social determinants of health remains extremely low. There is also no way to determine if hospital spending is tied to community needs. Hospitals may identify health equity priorities, but the current Form 990 Schedule H tool is inefficient at capturing how community benefit dollars address social determinants of health. And finally, community building activities do not currently count towards community benefit spending unless otherwise specified. And this spending accounted for less than 0.5% of total operating expenses in fiscal year 2016. Last year, the Montana Legislative Audit Division studied community benefit spending in the state and determined the program had no real impact on the health of Montanans. The disparate impact of COVID-19 has illustrated that prior efforts to address inequities were insufficient and health disparities persist. With barriers for meaningful community benefit oversight and accountability at the federal level, states are leading the way in addressing health inequities through community benefit policy. The following are some levers states are using to ensure meaningful community benefit spending. To set a minimum community benefit investment, Utah and Illinois require hospitals to spend the amount of their property tax exemption on community benefits. Oregon passed legislation to set spending floors for hospitals in 2019, which you will hear more about today. And additionally, legislation to create spending floors for nonprofit hospitals is currently being considered in Connecticut. States can also include community benefit requirements in their hospital licensing programs. Massachusetts and Connecticut have used their certificate of need and determination of need programs respectively to encourage meaningful hospital investments in community health needs. And states can also use audits and reporting to shed light on this issue. As previously mentioned, Montana conducted an analysis of community benefit spending in 2020 and determined only 4% of community benefit spending in 2016 went towards community health initiatives. The report recommended the legislature define reporting expectations for community benefit spending and its impact on community health. States can also require hospitals to link spending to identified community health needs. In Maryland, hospitals submit an annual report to the Health Services Cost Review Commission. This report must include hospital community benefit initiatives, the cost of each initiative, and a description of hospital efforts to track and reduce disparities. And in New York, hospital community health improvement plans must address goals in the state's larger prevention agenda. Lastly, states can pursue community service contributions by nonprofit hospitals. In New Jersey, Governor Phil Murphy signed legislation that requires hospitals to pay a $3 daily per bed community service contribution to their local governments. The purpose of this contribution is to support local governments in providing services these hospital taxes might otherwise support. As mentioned, there are a variety of policy and program levers states can use to address community benefits in their state. Today, you will hear from state officials in Massachusetts and Oregon address how their states have implemented these policies at the state level.
All right, thank you so much, Allie and Jill, and really all of NASHB for including Massachusetts in this conversation. We're really happy to be here. My name is Sandy Wolitsky. I'm the Deputy Chief of the Healthcare Division of the Massachusetts Attorney General's Office, and I'm joined today by my colleague, Noam Yosefi, who is a healthcare analyst in our division and who manages our state community benefits program. Today, I'll start by quickly reviewing the history of community benefits reporting in Massachusetts, and then I'll hand it over to Noam to describe some of the recent steps that the Attorney General's Office has taken to increase transparency, improve community engagement practices, and encourage regional collaboration and investments in upstream social determinants of health and health equity. Next slide, please. Though we don't have a statutory community benefits requirement in Massachusetts, we do have one of the oldest voluntary community benefits reporting systems nationwide. So the reporting framework for community benefits in Massachusetts dates back to the mid-1990s. At that time, in response to statewide discussion about Massachusetts hospital financial reporting and hospital community investments, the Attorney General's Office issued state guidelines back in 1994 on how nonprofit hospitals should plan and report on their community benefit, community health improvement programs. 2 years later, in recognition of the increased role played in our healthcare market by HMOs, the AGO issued guidelines, parallel guidelines for community health investments for health maintenance organizations. The Massachusetts approach to community benefits has evolved since the AGO developed its first guidelines. But I'll focus today on the most recent update to our guidelines and the work we've done over the last couple of years in Massachusetts. So Allie mentioned our state determination of need program and flagged that it intersects with our community benefits work in some important ways. So back in 2017, our State Department of Public Health completed a revision of our determination of need program, which included new requirements for hospitals to fund community-based health initiatives as part of state approval for significant capital investments, as well as some other triggers. These revisions really set the stage for our office to update our approach to community benefits. since both the determination of need community-based health initiatives and state community benefits programs are intended to address unmet community health needs. And clearly there's an opportunity there to provide some coordination to the needs assessments that inform this kind of investment. We were also mindful of the passage of the ACA and had a desire to harmonize our longstanding state requirements with the new federal framework where possible. But we felt it was really important not to lose the level of detail that we've historically received in Massachusetts state community benefits reports. So for example, Massachusetts hospitals each file a separate community benefits report with our office rather than submitting consolidated reports as part of a system. We also receive reports not only from nonprofit hospitals, but also, I mentioned our guidelines for HMOs, and we also receive reports from for-profit hospitals as well on a voluntary basis. In April of 2017, Massachusetts Attorney General Maura Healey convened an advisory task force on community benefits to advise her on the best approaches to modernizing these voluntary community benefits guidelines. And I'll just spend a moment on process here. So we felt it was really important to have the right voices at the table for this conversation. So we made sure that the task force included not only representatives from hospitals, health plans, community health centers, and public health offices, but also community leaders who could speak to statewide priorities like substance use disorder, healthcare affordability, and community development. So together with this multi-sectoral group of advisors, we examined how to promote hospital and HMO investments in addressing upstream systemic determinants of health and building health equity. We also discussed how to evaluate the impact and effectiveness of community health improvement programs. So informed by input from this task force, our office published updated community benefits guidelines and tools in 2018. The most recent published community benefits reports on fiscal year 19 activities and spending are the first set of reports to be submitted in accordance with these updated guidelines. So while our Massachusetts community benefits guidelines are voluntary, we have broad participation across both nonprofit and for-profit hospitals and from HMOs across the state. So last year, 58 out of 60 hospitals submitted community benefits reports to the Massachusetts Attorney General's office. And that actually includes all 10 of our for-profit hospitals. And with that introduction, I'll now turn it over to Noam, who's going to outline the key principles of our updated guidelines and to walk through some of the new reporting tools and the public database that we've built to share those reports.
Thanks, Sandy. So like Sandy said, I'll take a moment to review some of those key principles, and then we'll dive into a bit more detail around the new reporting tools and features that aim to improve community benefits planning and implementation. So first, we made changes to reduce unnecessary administrative burden by harmonizing federal and state requirements where appropriate. Second, we developed new tools to improve community engagement in the planning and implementation of programs. Third, we sought to increase transparency into key aspects of the community benefits process and expenditures. Fourth, the new guidelines encourage investment in statewide priorities and key social determinants of health. And finally, the new guideline to promote regional collaboration and learning. Next slide, please. So first, I'll discuss some of our new guidance and tools related to community engagement. Our guidelines encourage hospitals and HMOs to engage and collaborate with their community at the highest level feasible at each stage of program planning, implementation, and evaluation. And in accordance with our guidelines, hospitals should establish a Community Benefits Advisory Committee, or CBAC, and include members of the served population who reflect the racial, cultural, socioeconomic, and ethnic diversity of the community served. The CBAC should provide input to hospital leadership when designing the community benefits mission statement, the community health needs assessment, and the implementation strategy. And hospitals are also expected to hold a public meeting at least once a year to solicit feedback on its community benefits efforts. So our guidelines adopted the community engagement spectrum that you see at the bottom of this slide, which hospitals and HMOs use in their community engagement planning and evaluation. As you can see in this graphic, the level of community engagement can range from informing and consulting with community members to engaging in a community-driven or community-led approach, which represents the highest level of community engagement. This spectrum is used as a tool for evaluation and reporting on community engagement in our community representative feedback forms, as well as our self-assessment forms. And both of these forms are a central component of the state reporting. So first, hospitals are asked to distribute community representative feedback forms. The community representatives who serve on their community benefits advisory committee and any other individuals or organizations involved in the community benefits engagement process. And so these forms aim to solicit feedback on the hospital's level of community engagement in assessing community needs, in developing and implementing a plan to address the health needs identified in the process. Community representatives are then asked to share their feedback directly with our office, as well as with the hospital. And this tool is intended to help facilitate engaged dialogue between community representatives and the hospital. Hospitals are also asked to complete a self-assessment form. Hospitals fill out different forms based on whether they are in year 1, 2, or 3 of their community health needs assessment process. And through these forms, hospitals reflect on successes and challenges in community engagement and elaborate on their approaches to health equity and social determinants of health. The completed forms are filed with the AGO in each hospital's community benefits report and are available to the public through our website. The self-assessment form aims to increase transparency so that individuals and organizations can better understand how to participate in the community benefits process. In the FY19 reports, the self-assessment forms indicated that hospitals and HMOs vary widely in their approach to community engagement, in some cases aligning with feedback from community representatives. Next slide, please. The new guidelines also provide guidance on how to equitably integrate social determinants of health into a hospital's community benefits plan. In our guidelines, we anchor our discussion of social determinants of health with the Boston Public Health Commission's health equity framework. This framework illustrates how racism has an independent influence on all social determinants of health, and that racism in and of itself is harmful to health. Our guidelines aim to assist hospitals in recognizing and addressing the role that racism and institutional bias play in impacting health outcomes in their communities. And it's especially important that hospitals consider this framework and the race and ethnicity of served populations when identifying and prioritizing community needs. Next slide, please. We also aligned our guidelines to be consistent with other state initiatives to build long-term capacity in addressing common health priorities across the state. On the left side of the slide, we list the 4 statewide focus issues identified by the Executive Office of Health and Human Services, which were adopted in the new guidelines as areas that hospitals should consider as they plan and implement community benefits programs. We also encourage hospitals to consider 6 health priorities adopted by our Department of Public Health in its updated determination of need regulations listed to the right of the circle. These health priorities underscore the importance of investing in key social determinants of health that impact health outcomes, such as education, employment, and housing. Our new reporting system offers hospitals an opportunity to indicate which of their community benefits programs and expenditures are aimed at addressing these shared health priorities. Next slide, please. Our guidelines also encourage hospitals to collaborate with other hospitals, insurers, local public health departments, and community organizations in conducting their community health needs assessments, developing implementation strategies, and sharing best practices. And many Massachusetts hospitals and health plans have or are engaging in joint CHNAs and implementation strategies to come together in addressing regional health needs. And we're really excited. These joint efforts have the greatest potential to impact community-wide health in the Commonwealth. Our updated reporting system provides hospitals with an opportunity to highlight these collaborative efforts and allows them to report expenditures that go towards infrastructure to support community benefit collaboration. Next slide, please. Finally, our new reporting system offers hospitals and HMOs a more comprehensive and robust selection of attributes or program tags to provide further transparency into the health needs and target populations being addressed through their programming. Program descriptors include program type, age group, gender, race and ethnicity, region and environment served, language, and health issue. Hospitals and HMOs are also able to tag their programs with the statewide health issues and determination of need priorities that I mentioned earlier. We also provide hospitals and HMOs with an additional tag to indicate when community benefits investments are designed to improve the health of specific vulnerable populations, such as individuals with disability status, domestic violence history, immigrant status, or incarceration history. This program data is then funneled into our online database, which allows members of the public, academic researchers, and industry stakeholders to sort through a public searchable record of community benefits programs by filtering through the same categories that hospitals now use to describe their programs. So for example, members of the public can filter all FY19 community benefits programs to identify programs aimed at addressing substance use disorders among Spanish-speaking youth in Springfield. Or they can filter to find programs focused on reducing Black maternal and infant mortality that aim to prevent housing instability or homelessness in Boston. In addition to the general public, we encourage hospitals and HMOs to use this information to identify best practices and possible partners, reduce program redundancy, and leverage joint resources for greater impact. Thank you again to NASHP for inviting us to present on our state's community benefits program. We look forward to answering any questions.
Fantastic. Thank you both Sandra and Noam for that presentation. And now we will turn it over to our Oregon partners.
Great. Thank you, Jill. Thanks, everyone. It's so great to be on a NASHP webinar with our Massachusetts colleagues and NASHP friends. I'm Amy Clary, and I manage the Research and Data Unit within the Office of Health Analytics at the Oregon Health Authority. And it's the Research and Data Unit that includes the Hospital Reporting Program, where our Community Benefit Program sits. And I'm joined today by my colleague, Hospital Policy Advisor, Stephen Ranzoni. All right, next slide, please. So as I mentioned, it's great being on this webinar with our Massachusetts colleagues. Unlike Massachusetts, our program is statutory, and this timeline tells you a little bit about Oregon's activity in community benefit over the years. And this slide shows some of our incremental changes in the growth of our program. Our cost-based system was innovative in 2017 when it started as a result of legislation passed. 2015 saw us moving to a new standardized format for our public-facing reports, and reporting, as you'll hear, remains very important to our program. And then in 2019, it was House Bill 3076 that was passed by the legislature and signed into law. And that bill included activities that address health disparities and social determinants of health in the definition of community benefit. And you can see that change in red font there. So in addition to the changes brought about by HB 3076, we are also moving our reporting to an interactive online format in order to encourage the kinds of community benefit investments that align with other OHA priorities related to equity, costs, and the social determinants of health. And I should say that we are learning from our Massachusetts colleagues about the power of reporting to encourage these kinds of investments. And so this the group that NASHP convenes has been really helpful as we shape our thinking about that. All right, next slide, please. So HB 3076 in 2019, it also increased hospital financial assistance. It instituted a minimum community benefit spending floor, so you'll hear more about that soon. And it also eliminated Medicare shortfall as a category of unreimbursed cost, even though the IRS still counts it. OHA rules allow hospitals to meet their community benefit obligation by spending in any of the 10 categories of community benefit and those categories encompass unreimbursed costs of care, health professions, education, and research, and the kind of direct community investments that are more likely to encompass equity, social determinants, and upstream health improvement. Next slide, please. So as I mentioned, in addition to the minimum spending floor, it's important to call out, and this I feel like sometimes gets lost in the well-merited attention to the spending floor, but HB 3076 also increased financial assistance which benefits not only the uninsured, but also the underinsured folks with low incomes, high deductibles, and high copays. And just wanted to note that any amounts waived by the hospital as a result of these requirements are counted as charity care for purposes of community benefit reporting. And next slide, please. So as mentioned, the Community Benefit Minimum Spending Floor Program and Community Benefit Program more generally, this program seeks to encourage investments in health equity and the social determinants of health in alignment with other programs. And I should note that the Oregon Health Authority has set a goal of eliminating health inequities by 2030, and this program is aligned with that goal. And to that end, we will be launching in the coming months a new reporting template that asks hospitals to identify community benefit activities that address social determinants of health or health equity, including at a population level. And it will ask about activities that address individual health-related social needs and about activities that address systemic issues or root causes of health and health equity. And we're expecting that reporting to give us a window into the types of investments that hospitals are making into health and health equity. And we look forward to having that data as the program matures. And I wanted to also mention that program rules require that a hospital that works with a coordinated care organization or a public health agency requires them to it requires a hospital that works with a CCO or public health agency to address community needs, requires them to report that activity to us. And our rules also require us to consider needs identified in the coordinated care organization's community health needs assessment and community health improvement plans. The community benefit program also aligns with OHA priorities by encouraging hospitals to invest in health upstream. And all of those activities have the potential to impact cost, and the reporting that we're doing as part of this program provides another line of sight into hospital finances. So our team works closely with other programs across the agency and across Oregon state government that are working on disparities, social determinants of health, and healthcare costs all at the same time. And our community benefit minimum spending floor program is one of the real linchpins to this body of work. And so I want to turn it over now to Stephen Ranzoni to tell you a little bit more in greater detail about the spending floor. Next slide, please.
Yes, thank you, Amy. As she introduced me, I am Stephen Ranzoni, a hospital policy advisor. I work on Amy's team, and I help program manage our hospital reporting program. The House Bill 3076 that brought about what I would call a paradigm shift in community benefit in Oregon. One of the major points of this was a new community benefit minimum spending floor. With this bill passage, Oregon became the 6th state in the nation, pretty sure that's still accurate, to have a spending floor of any kind. We're the only one that actually does something to tailor the spending floor to the particulars of the hospital, to actually put it through some kind of a methodological assessment to get there. The program became effective this year on January 1st, 2021, and we began the process of rolling out spending floors with the start of all the hospitals' upcoming 2022 fiscal years. And so that meant 2 floors have been assigned so far. We have a large batch about to happen for some state years, some July 1st fiscal years, and then the rest of them as the years start rolling out. Next slide, please. So I think one really important thing to talk about is that this spending floor was not of OHA's making. We did not write this bill. We did not put this bill through. This bill came about via an activist legislature and a lot of interested parties in the state. And so that the bill got written for OHA to implement. And with that, the bill prescribed a number of things that OHA had to consider when developing the methodology to assign the minimum spending floor. This slide highlights a couple of the key points that the bill spelled out. I won't go through and read them all, but basically, more or less, it directed us to consider the finances of the hospital, what they've historically done in terms of community benefit, financial spending, the demographics, and taxes paid, or other factors such as that. Next slide, please. Other requirements of the bill was principally that we had to work with the hospitals in developing this methodology. We had to seek input from the general public, and we did have to seek input from individuals with expertise in the economics of healthcare. We did do that. We consulted with experts at Johns Hopkins University and George Washington University in developing this methodology, and got their thumbs up for it, which is good. And then one really big caveat to this bill is we did have to allow hospitals the flexibility to have the spending floor applied to themselves and their affiliated clinics in more or less, this is kind of a paraphrasing, but more or less however they choose. And so it can be one spending floor per hospital. It could be a single spending floor across an entire health system, or really almost anything in between. Next slide, please. We adopted, and so, the bill gave OHA a set of criteria within to work in. We approached this by setting a couple of guiding principles as to how we wanted to develop this methodology. First was that the idea that financial assistance isn't limited. As Amy mentioned earlier, as part of 3076, we defined financial assistance in statute at a very high, relative to the nation, at a very high level of the federal poverty limit. And so states have to be performing at a high level of hospitals at a high level of financial assistance at a fairly high level of income. And so we didn't want to develop a methodology that was going to in some way limit that, or in any way try to incentivize hospitals avoiding that obligation. And so its presence, and we'll talk about more about this in detail, its presence is to simply exist as an ongoing trend. We recognize that this spending floor had to apply to all our categories of community benefit, and anything that they do across any of our recognized categories in the state of Oregon can work towards the spending floor. We wanted it to look forward. We wanted hospitals to know that they had a number that they could budget towards and plan towards. We wanted it to use our existing data systems. We didn't want to invent anything new. It had to be a simple, scalable, and flexible program that anybody without a lot of skills or background in statistics or whatever could work within. And then we didn't want a system that would create any kind of downward trend, which is the most significant pushback that you tend to hear about community benefit spending floors, as much as that if you set a floor, you have now just set your ceiling at the same time, and spending is actually going to decrease over time. Next slide. So with all that background, here's the good stuff. This is our methodology. And so how we go about setting it is we do it in a 2-year cycle. And each year within that 2 years has its own specific floor. So we'll set the first year of the 2 years with this methodology. We take the 3-year average of the hospital's unreimbursed care spending. To that, we add a percentage of their net patient revenue. To us, that represents what we call direct spending. That's the stuff that's like community building, community health improvement services, cash in kind contributions, et cetera. And then we modify that amount by the hospital's operating margin, up or down, depending on their financial position. The year 2 amount is then just flat adjusted as a % up and down based on a 4-year trend of their net patient revenue. And so if they have been trending up in time, we will adjust their spending floor in line with their net patient revenue growth. If the opposite is true, we would also adjust it downward. Next slide. So we're going to break up all those components a little bit more closely. I did note this before, so I'll be a little bit brief here. Unreimbursed care is basically defined in statute in Oregon. We want hospitals to always be meeting the need. We don't want to try to cap it. And we don't want to try to limit it. If somebody walks in their hospital and they're eligible, they get it, and that's that. And so all we are trying to do is establish an ongoing trend for hospitals with this methodology. What we really always want it to be, we tell hospitals this all the time, is that you are meeting the need. And that number should really define itself. Next slide. Where we really want to put emphasis, and where I think, you know, from our colleagues at Massachusetts, all the way before with Allie's presentation, and as most of us know, most community benefit is that unreimbursed care. We're really trying to promote the active spending. And so this is where a part of the methodology where we looked into try to bolster and put a focus on activities and community benefits, such as social determinants of health spending, such as community building, cash in kind contributions, and such forth. And so what we did is we historically looked across all the spending in the state, generated a bunch of descriptive statistics, and drew a line at essentially above the median performance of a hospital, and designated a percentage of net patient revenue that puts upward pressure on this amount of money. And so as you can see, for our large urban hospitals in Oregon, we have a naming system. We just call them the DRG hospitals. They're expected to spend about 1.5% of their net patient revenue towards this, and whereas our smaller rural hospitals are set at 1% of their net patient revenue. Next slide, please. We were instructed in the bill that we needed to consider the finances of the hospital, the financial position of the hospitals. And so with that, we take their average operating margin over the last 3 years. If it's low or below 0, we will downward adjust that direct spending contribution amount. And likewise, if the performance is strong and they have high margins, we're going to actually increase that amount to a higher percentage. We only apply this to the direct spending portion because, again, as we said several times, unreimbursed care is always meeting the need, right? You're always doing that. And so the area that we view of flexibility, in as much as that there can be, is the degree to which hospitals have the flexibility to spend money in those other areas. And next slide. Transparency is a key part of our program. The power of this program, so much more than a spending floor, is the idea that we're putting it out in the public, that we're advertising what these spending floors are, that hospitals are going to begin to write more descriptive narratives about how they're spending, how their program works, where they're addressing their needs at. And we're taking all of this information and we're putting it on our website. We wrote into our rules that every part of this program is open to public comment, and we put that notice out there. And so whenever we issue a new proposed spending floor, whenever we issue a final spending floor, the public has opportunity to make comments towards us, and we publish those comments. It has already happened when we issued our first spending floor to the legacy health system. We got public comments on that, able to post that on our website for people to see. And that will always be an ongoing part of this program, is keeping everything that we do in the public sphere. With that, and related, I believe, yeah, let's just go to the next slide. We've put a lot of time and effort into developing a new interactive dashboard using Tableau. And so we took all our data, and made this really great interactive dashboard. So as it stands right now, what it has is just the historic performance, to date as to what Oregon has been doing. And that's great data to go explore. As we move on through and start collecting information on the spending floors, we will start introducing more metrics and more information into this dashboard, such as hospitals' performance against their spending floor and other insights from when we start gathering this more information. And next slide. And so with the spending floor, we do have some new reporting requirements. Nothing has changed from our previous, as Amy introduced in the early slide. There's always been an obligation to report your costs associated with community benefits. That doesn't change, they're still doing that. But we have added more. They have to, beginning in FY 2022, which coincides with their first spending floor year, they have to start writing up these descriptive supplemental narratives about their community benefit program. We've defined it for them and spelled out to what degree that they have to answer. But at the very high level, it's who did they partner with, what were the health needs that they've identified, how did they go about addressing those identified health needs, and then very specifically, what investments in social determinants of health did they make. We did take the next step in that and divided up our concept of social determinants of health between what we would call addressing a specific social need versus working towards advocacy or making systemic changes in the population. And so they have to talk about both those levels of social determinants of health. Next slide. Looking ahead to what we have, we had the great fortune of introducing this program in the middle of a pandemic. It really got interesting with hospital financials and disentangling what really happened with net patient revenue versus the support money that came in that was substantial for many hospitals, and how we navigate those waters has been an added complexity to us. Fortunately, by our design, a lot of this stuff gets mellowed out as I've been looking due to the fact that we use multi-year trends. But COVID was super impactful, obviously, and so that is a challenge. And then the ongoing growth of unreimbursed care in a hospital as a category of community benefit is a challenge. It is and will always remain the outsized portion of community benefit. And how do we shift the focus off of counting or considering, unreimbursed Medicaid and those costs, and try to get more focus in the preventative care and in the direct spending, as we call it in Oregon, over that. And our opportunities, again, with being public, focusing on our collaborations with the CCOs, trying to foster the strong shared health needs assessment, the shared investments, and really trying to get that collaboration going, I think can bear fruit. And then really, again, we have this great opportunity to re-emphasize population health strategies versus, acute care interventions versus, one-on-one type of interventions. And then last slide. Or second to last slide. This is just a list of our resources if you want more. The link here that will take you to our website, where we have a lot of information. You'll be able to access that Tableau dashboard that I spoke of previously, as well as view a tremendous wealth of information that we provide about all our hospitals, including detailed financial information, all the forms that we collect, and a lot of really good stuff. We have a lot of transparency in Oregon around our hospitals, and you can find all that information on our website. Here is all our contact information if you have further questions down below on the slide. And I think that's my last slide.
Excellent. Thank you so much. And thank you, all of our speakers. I think you've really shared some really interesting details about ways that community benefit policy can address and encourage hospital spending on community building, social determinants, and equity, and the critical partners for aligning priorities across state agencies, and also the importance of reporting and transparency for these policies. So thank you for all of that. Stephen just touched on COVID. I think we may come back to COVID in a minute. But to start with a question, and let me also just make sure everyone is now ready to ask questions. So you can go into the Q&A and post your questions there, and we're happy to address them. And so just to address the first question, which is a question from Massachusetts about how is collaboration with other hospitals, insurers, and others incentivized? Has this led to more meaningful investment in communities?
Yeah, it's a great question. So we require, as part of the self-assessment forms that hospitals fill out, for hospitals to report on their participation in any regional collaborations around a CHIP or a community health improvement program and planning process, and ask them to explain why they don't participate in such a process if they say no, and also ask for a similar kind of explanation around participation in shared regional planning around community health needs assessments and implementation strategies. So we're excited to have a public record of how hospitals are approaching the decision to work alongside area insurers, community groups, other hospitals who work in the same area. The second part of your question, though, has this led to more meaningful investment? I mean, that's the important question that we want to answer too. And I shared that we're now looking at the first year of hospital reports under these guidelines. So I think what we have now is really going to be a baseline for testing this and where the impact is. I can say that over the last couple of years, there's been really positive growth in the collaborative development, particularly of community health needs assessments in Massachusetts. Like in 2019, the Boston area hospitals came together along with community-based organizations to complete a regional CHNA. Of course, that predated the effective date of our guidelines, so we can't claim that as a product of our reporting framing, but just an example of the work that's happening in Massachusetts.
Great, thank you. There's a question about the role of health professions education spending in community benefit now and in the future. Would anyone like to take a stab at that one?
I mean, for Oregon, I can say that we definitely consider it. It's one of our categories of spending. It will always be one of our categories of spending. Like everything we collect in Oregon, we collect a net cost. So you have to deduct any offsetting revenue you have from that. And I would also say it's something that we definitely encourage. There's a need for promoting the future healthcare workers in the state, particularly if they're going to go out to a rural hospital where we have most of the need.
And I would just add to that the dashboard that Stephen shared before has that as a category, of course, and so we can track how the percentage of that as overall community benefit spending has changed over the years.
Great, thank you. Sandra, did you want to answer that one?
Well, I'll just add kind of one perspective from Massachusetts, where we use the kind of core planning documents, the community health needs assessment and implementation strategy, as sort of the rubric in assessing what costs can be reported in the state community benefits reports. So, when we see reports around, medical and, clinical education and research as well, the standard is, whether those investments correspond to an identified need in the community, and whether the education and research advance a priority that's surfaced through the community benefits planning documents. So it's a different approach from the 990s and from other states, but I think what this kind of rubric and core framing allows us to do is to kind of get at what Stephen was talking about, kind of focusing on the direct affirmative spend and sort of making sure that it's tied to an authentic and community-driven needs assessment process.
Great, thank you. We don't have too much time left, and there's lots of interesting questions we could explore, but I think it would be helpful if each state might comment on your lessons for other states that want to take on this topic, and what you would recommend to them in starting.
It's a great question, Jill. I would say our decades of community benefits experience in Massachusetts has really focused on the quality of the reports that we make publicly available. And, our stance has been to work alongside hospitals, nonprofit and for-profit, and HMOs to, incentivize and encourage them to voluntarily submit this information in a way that is easy for the public to access. And we've found that, through this voluntary guideline framework, we've been able to gather information about, hospital level community health investments, in a way that I think allows for transparency that goes far beyond what we get from reviewing the 990s. So I would encourage, states that are thinking about changes to their community benefits programs to really think about what they want to see in those reports and how that data can be used, not just by researchers or academics or even, community leaders, but also by other hospitals, other community benefits staff, who are looking for ideas and collaborators or, areas where they've identified a community need, but in fact, it's well served by other, community benefits offerings in the region. So I would say start with what you want the report to include, and then think about the most effective way to either encourage, incentivize, or require the production of that information to the right state agency.
Fantastic, thank you. Oregon.
A couple quick thoughts. Oh, sorry, just a couple. Transparency, of course, is key to all of our efforts, as Stephen pointed out. I also wanted to harken back to when Sandy was talking about the big stakeholder initiatives that process that they went through. I just wanted to note when we were doing rulemaking for this, Stephen led a really inclusive rulemaking process that brought all our stakeholders to the table, and I think that made a big difference. Stephen, go ahead.
I was just going to offer that if your state hasn't begun work or doesn't have a program, you have to start with data. You can't jump in the deep end with policy and laws and regulations if you don't have really good state specific data. And it's really hard to work on the lag of the 990. And then if you could ever apply it to your even if policies don't apply to it, but if you could ever get information out of your for-profit facilities, it's beneficial. So if you haven't begun somewhere in your state, begin by starting a data collection program.
Yeah, great point. Thank you. Well, thank you all so much. If there are any remaining questions, I will say if you reach out to us at NASHB, we are happy to help get the answers to your questions. I do want to also just make a point of mentioning that we do have resources on our website and tools that states can actually fill out and get started on some of this, as well as blogs that feature both Oregon and Massachusetts. And so we would encourage you to go there to look at those. We'd also like to ask everyone to please fill out our evaluation form at the end. It really does help us to tailor our resources to what may help you advance your work. And then if you are a state official and you would like to join NASHB's community benefit work group to explore potential strategies that you could use in your state, please let us know that as well. You can let us know that on your evaluation, or you can reach out to Eleanor Higgins. We have her address on a slide, well, you can also reach out to us however you registered. Any of us at NASHB are happy to help you with that. And I would just like to thank our 4 or 5 panelists for sharing your time and your expertise with us today. And thank Robert Wood Johnson for supporting the work. The webinar and the recording, the slides will be posted on our website and available to all of you in a couple days. And I'll thank you all for joining and have a good rest of your day. Thank you.